medicine. The subjects for discussion are first, human limitations. Next, the fact that we need models or tools to help us achieve our desired actions. I want to present to you a partial cure for this problem that has in fact been addressed, albeit intermittently, for the past 70 years without much progress in professional medicine. And this involves what we originally called e-protocols, now call e-actions because they're focused on the actions of physicians and involves computerized replicable methods. So let's start with human limitations. What's our goal? Well, Brent James used to articulate this at Intermountain Healthcare by pointing out that our goal was to make the evidence-based decision the first time and every time. Now, why? Well, because it makes a difference to patient outcome. Here are data from Kfouri and others with survival of patients on the left and the vertical axis, and the number of core heart failure measurements or measures that are adopted. Now, these core measures on your right, going from 0 to 4, are very high level. They're process measures. So it's things like, do you have a protocol for educating patients at the time of discharge? No details about the protocol, nothing that comes even close to what everybody in this room would have to do to make decisions. But look at what he reported. When you go from none to 4 of these high-level process measurements, the 12-month survival increases from about 73% to about 94%. Now, this is not proof, it's not an experiment, but it's a strong suggestion that it makes a big impact if you do what evidence tells us is a good thing to do for patient outcome. Now, I'm not going to spend any time on the bottom with the citations. They're there for those of you who want to review these slides at some point in the future and pursue anything. You've got the references, but we won't discuss them. So this leads to a basic question. How good are our decisions? We're all trained. Most of us think we're well trained. And let's take a look at children evaluated for tonsillectomy. Now, I unfortunately don't have my notes, so I'm trying to remember my notes. Is Dr. Gonzalez in the audience? No. He has an interest in tonsillectomy. Well, here are some data. For those of you who haven't looked at the throat in a long time, those are the tonsils. 389 children were presented to a panel of physicians. And they decided that 45% of them needed to be referred for tonsillectomy. The remaining 175 children who were not sent for tonsillectomy were presented to a second panel of physicians. And they decided that 46 of them needed to be referred for tonsillectomy. The remaining 80 children who were not referred for tonsillectomy were presented to a third panel of physicians, and they decided that 44% of them needed to be referred for tonsillectomy. Now, this is about the time when I was a young boy and had my tonsils removed, but I don't know if I was part of this study. The study was published in the New England Journal in 1945. it certainly raises some question about our diagnostic acumen, our behavioral rules, and our performance. But it doesn't demean physicians. It just points to the fact that physicians belong, like other people, to the group of Homo sapiens. Now, to carry that, how well do we do a little further, we can ask, what's the physician compliance with guidelines and evidence? Well, for gout, 10 different studies had compliance with the best evidence-based care varying from 3 to 71% of the time. For mechanical ventilation, any critical care docs in the audience? No? This was called by a number of reviewers the most important study ever produced in critical care, published in 2000 in the New England Journal. 12 or 14 years later, only 65% of eligible patients got lung protective ventilation, a life-saving change in strategy. For surviving sepsis campaign, the bundle is adhered to, complied with by clinicians from 15 to 20% of the time. For emergency department management of hepatic encephalopathy, within 1 day, 22% of physicians complied with the best evidence-based care. For Veterans Administration hospital use of outpatient antibiotics, 20% complied with evidence-based care. And when infectious disease was consulted and we had the experts involved, that 20% rose to 54%. And finally, it's not just an American problem. For Canadian primary care physicians, managing 13 chronic kidney disease quality issues, that was complied with by 18 to 86% of physicians. Now just ask yourself, what other human behaviors would you feel comfortable with if pilots or any one of a number of other humans told you that they comply with the best evidence and how to get you safely from point A to point B about half of the time? But in medicine, when you read papers, you'll commonly read somebody touting their progress when they've increased compliance from 30% to 37%. Think of the children you've had in school and what you would say if one of them came back from the math midterm and said, "Mom, Dad, I increased my performance by 33% on the midterm. Last time I got 15% right, and this time I got 20% of the questions right." Hardly an issue for generating a familial celebration. So we have a major problem. Now, here is a quote from Intermountain Stories, cited by Rob Allen, the Chief Operating Officer, in 2018. He said, "We're nationally and internationally known for the design of quality care, and our caregivers have done an amazing job for decades. With all we know about how to give the best evidence-based care to patients, we do it maybe 40% of the time." Now, here is a picture of the Gare de l'Ouest, the Western Railroad station in Paris, France, at the end of the 19th century. You don't have to have good sight or good hearing to know that something very bad has occurred. But that signal is huge. Most of what we pursue in healthcare has small signal to noise ratios, the noise being all the other stuff that floods us, but we're not interested in. So most of what we explore has small signal to noise ratio and requires careful, systematic study. It's not obvious, like this accident. Now that moves us to the issue of sight. What do we see when we look around? And I can point those who are interested to a paper that appeared just a couple of months ago in Trends in Cognitive Science. And in this paper, the title is Rationality, Preferences, and Emotions with Biological Constraints. It all starts from our senses. So let's look at our senses and keep in mind an aphorism. Seeing is believing. There are even biblical foundations for that aphorism. You get two witnesses who see the same thing, it's got to be right. What they point out in this very interesting paper is that biological information processing is costly. Now, our brains, on average, constitute about 2% of body weight. 2%. But our brains consume about 20% of our energy and our oxygen consumption. So you've got this small mass, but it's, from the biological perspective, very inefficient, because when you run this small mass of brain material, it consumes a lot of energy. That means a lot more hunting and a lot more food consumption. So from the biological perspective, they point out that sensing output systems like the brain have noisy channels, and they always lose information. They point out that our senses, from the biological perspective, should adapt an adjustment at the earliest possible stage to maximize the efficiency. And from that come two conclusions that I find stunning. The first is, our senses are not intended to enrich subjective experience, but intended instead to increase survival. So when you walk outside and take a look at a nice snow-capped mountain and think, as I did, driving up here from Salt Lake City this morning, boy, that's beautiful. That's not what our senses are intended to do. They're not intended to make you admire Monet's water lilies. The other conclusion is representing the world as accurately as possible is probably not the purpose of our senses. Now, think of that for a moment. Medicine is an applied science. Science needs to perceive the world accurately, but our senses aren't intended to do that. Contrast that with this quote I took from the History of Your Society in the material I received before this meeting. This is from John Hunter, one of our famous predecessors 2 centuries, more than 2 centuries ago. He said, information furnished with the senses is intended to reflect the properties of things and lead us to knowledge. So now we have this contrast between what our senses are intended to do for knowledge acquisition and what our senses can do. Now, much depends on the target. If your target is to avoid being eaten by a lion, and thus being better enabled to get your genes into the next generation or two, then recognizing patterns is a good thing. And whether you recognize the lion correctly 73% of the time, or 67, or 81, or 49 is not as important as recognizing the lion more frequently than your competitors, like Neanderthals or Denisovans. On the other hand, if Brent James is right, and I think he is in medicine and healthcare, if our goal is to provide evidence-based treatment the first and every time, then we have to accurately sense and interpret the world. So let's do an experiment right now. Take your hands, put one as far away as you can, and one, maybe 4 or 5 inches from your eyes. And look back and forth to your hands and assess their size. Now, I'm going to take the hand on the right here and replace it with the mirror image of the one on the left to make them identical. Because I want to use the inverse square law to make the following point. Now here is the image, the blue image on your retina from the hand that's close to your eyes, the one that's 4 or 5 inches away. In red is the image on the retina of the hand that's as far away as you can get. Now, when you look at them like this, they look about the same size. But if you put a camera where your eye is, that's what the camera sees. That's what impinges your retina. But it's not what we perceive. You'll notice that the right hand is smaller than your fingers. But if you do this, it doesn't look that way at all. So here is the dilemma. The retina sees this reflected by the camera. But our brain perceives hands that are about the same size because our brain sees the world through internal models. You know what the hand is like. You've got experience viewing the hand, using the hand. So when you see something that's supposed to be the hand, you make it the hand to fit the model of the hand. Now, I've used a visual indicator, but there are other models, philosophical models, religious models, behavioral models, child rearing models, models of how the body works, which leads to biases about treatments. Our brain is filled with models. And science needs us to describe the world as it is, not as we perceive it. Now, here is a picture of the Apple store at Fashion Place Mall in Salt Lake City. If you stand where this picture is taken, it doesn't look like that at all. The dramatic convergence of the two walls doesn't occur because you have models of what a room is like. Now, interestingly, that convergence does occur in Leonardo da Vinci's painting of the Last Supper in Milan. This fresco was done by an artist who was very interested in the camera obscura. which is a room with a pinhole in it on which an image is projected. And it's from the camera obscura that we get the word camera for photographic camera. So he was trying to represent in what's called an architectural approach to painting the world as it really is, but not as we see it. So how good are our perceptions for identifying the world? Now, IT guys, this is a video. Can you play it? These two squares are the same shade. Watch what happens. When she puts it back, it won't even exactly overlap. Now, even when we know those two squares are identical, we cannot see them. We cannot perceive them as they are because of a shadow and a post and models we have in our head. So Neil deGrasse Tyson said this very well. If we were honest about the shortcomings of human physiology, the optical illusions would instead be labeled brain failures. Failures to accurately reflect the world. Now, that was a key part of this presentation, because understanding that we're not as good as we're taught we are is a prerequisite to fixing the problem of doing the right thing only 50% of the time. And if you don't believe what's just been presented, it's going to be hard to swallow the rest of this proposal. Now, to look at the tools we need to help us over this barrier, we ought to first address what we say about ourselves. Here is a statement by Ezekiel Emanuel from the National Institutes of Health, indicating that actually the really good ones among us can do this very well. So let's look at how we manage complexity and whether it really sets us apart. Now, I'm guessing that virtually everybody in this room, when they were medical students, did a spirogram, a forced exhalation into a spirometer, right? Okay, what does that involve? Well, there are three variables: time, volume, and flow. And for decades, we've had programs that easily handle those variables, allow you to rotate the three-dimensional plot to see everything. And what do the experts do in the pulmonary laboratory? Well, they either plot volume against time, or they plot expired flow against volume. Why? Well, it's just too damn hard to deal with three variables at the same time. It's just too big a challenge. Ooh, if three variables are too big a challenge, what about the many hundreds of variables in a patient with sepsis and hypotension being mechanically ventilated? What about the hundreds of variables in the patient with chronic inflammatory bowel disease who's got an immunologic problem and perhaps been immunologically suppressed with one of the drugs that the appropriate advertisement got your patient to ask you if it was appropriate for them. Let's take a look at this. What do you see? Anybody? Faces, two faces facing each other, or a vase. Now, try and see them both at the same time. Try and see the face and the vase, and not be flipping back and forth from one to the other. It's not manageable. Two different images. We can't even keep two different images together at the same time. So let's look at a partial cure. And I'm intending we'll have a number of minutes available for discussion with what we're calling e-actions that leads to replicable methods. This started with a clinical trial of mechanical ventilation for patients with acute respiratory distress syndrome. The patient provides some data according to information technology standards. Those data that here include pulse oximetry and arterial PO2 and pH and respiratory care data drive rules that return patient-specific, personalized medicine instructions. Those rules are displayed to the clinicians, and the clinicians accept those 95% of the time, unless it's automated. If it's made automatic, then they accept the rules 100% of the time. For the 5% that are rejected, if they decline the instructions, we capture the reason. Now, it took us a year or a year and a half to develop these rules for a clinical trial. It wasn't known if it was possible. That's a big investment. But let's look at the return on investment. Over the next 30 years, at Intermountain Healthcare institutions and at other hospitals, those rules, after the study, were used for care about 2 million times in about 21,000 patients. That's a pretty good return on investment. And the rules were consistently executed in part of routine care. Now, what are replicable methods? Here are the instructions from one of the runs of one of those protocols. Reminds people that they were getting 90% and now it goes to 80%. Tells them when to reassess. Tells them what tidal volume to give. Tells them to increase the ventilatory rate from 22 to 25 a minute, and when to sample the blood. Now these, given the same input data for different patients, will yield exactly the same treatment instruction. But the standardized decisions and treatment instructions are not equal to standardized care. Because remember, the care of the patient is a sequence of interactions with the e-actions protocol. And each interaction depends upon the response of the patient. And each patient responds a bit differently. So exactly the same rules for management lead to different care plans for the patient, but we know exactly what the method is. Here is what you can achieve with that. These data were acquired by Jim Orm Jr. at LDS Hospital a number of years ago in a study that provided the foundation for the Acute Respiratory Distress Syndrome Network study I mentioned to you just earlier. Here are two different groups, one with a target of 12 milliliters per kilogram and another a target of 6 milliliters per kilogram. And you can see that they're very nicely separated. So the intervention under study can be controlled very, very carefully. Intermediate outcomes, also called endpoints, and as I'll show you in a moment, also called co-interventions, because if we're studying tidal volume, but not controlling arterial PO2 or arterial pH or fluid or antibiotic administration, then those things that can influence the outcome but are not being studied are labeled co-interventions. They're just not the intervention of study. And very often they're not controlled at all in clinical trials. So here is the mean PO2 from 151 measurements in the higher tidal volume group. And here, for about the same number of measurements, is an almost identical mean arterial PO2 in the lower tidal volume group. So that co-intervention is being controlled. And here is the study for which we made the first rules. PCIRV is pressure-controlled inverse ratio ventilation and extracorporeal CO2 removal, a heart-lung machine use. And the mechanical ventilation line, the solid black line, is just standard mechanical ventilation, but according to the rules that we developed. There was no difference in the survival of these two groups, which was an unanticipated outcome. But look at the co-intervention at the end of the study of the PO2 in those two groups. They're identical. Now, any pediatricians in the audience? No pediatricians. Any physicians in the audience? Oh, yeah, good. I just want to make sure you were responsive. Okay, so here is another example of a replicable method. This was for managing glucose in the intensive care unit. And this was used in terribly sick patients my age, and also in pediatric ICU where you might have a 3-month-old with bronchiolitis being mechanically ventilated and having glucose management problems. Exactly the same application, same rules, same tool, no modifications whatsoever. So here is the countdown timer in the middle and the instruction, which I've enlarged to make it clear what this does. Let me show you what that can achieve. Here is a comparison of 3 ways of managing blood glucose. Tufts University had a simple guideline. Doesn't get more simple than this. The guideline said, get the blood glucose between 80 and 110 milligrams per deciliter, and that was it. And all the nurses and doctors accepted it. At the University of Virginia, they had a paper protocol with more detail. And then at LDS Hospital, we had an e-protocol that we now call e-actions, this detailed computer protocol. Now here are the distributions of blood glucose with percent of blood glucose measures on the vertical axis and blood glucose value on the horizontal axis. The target range is shaded. These are different institutions. The IT people, just for your note, there's some wrapping of the text, which is why I wanted to present from my own computer. And the solid black line is the performance at LDS Hospital, and the dashed line in red is at the University of Virginia, and the simple guideline at Tufts in green. Now, the difference in anticipated survival between the black distribution and the green distribution is about 10%. If I told you about a drug that reduced absolute mortality by 10%, you would recommend that everybody in your family buy stock in the company immediately. Now, there's a problem with the guideline and the paper because bedside clinicians add the detail that's missing in the protocol and the paper. As a result, we don't really know the method of care. For example, the method includes the high-level rules in the protocol and guideline, plus the unknown and unarticulated physician decision rules that take place at the bedside. So we never really know the method and can't duplicate it. What we did was exported the electronic protocol to a group of uninvolved hospitals that had nothing to do with the development of the rules in the US and at the National University Hospital of Singapore. And all of the differences disappeared, indicating that it was possible to take rules developed at one site in Utah and export them to different parts of the world and have them perform the same. Now, in addition, in the same hospital, we then took the research results in black and just in a matter of 30 seconds, switched it over to clinical care and used it for clinical care. And that's the red dashed line. And the performance is almost identical. In the same corporation, but not the same hospital, we then distributed that tool to multiple hospitals, and the compliance at the multiple hospitals was 92%, which was just a little bit lower than the 95% at LDS Hospital. And then finally, we used the adult performance and compared it with, in the black curve, and compared it with 3 pediatric ICUs. In blue, in Western USA, that's Primary Children's Hospital, and in the Southwest and Southeast are 2 other pediatric ICUs, one in Florida and one in, I think Virginia, but I may be misremembering that. The compliance in the pediatric ICUs was about 90%, a little lower than in the adult ICUs. Pediatricians are a lot more sensitive to blood glucose management than adult physicians. That was just to point out to you about 20,000 adult patients and about 15,000 pediatric patients. Now, finally, a completely independent study done at Harvard in multiple sites by Agus and colleagues and published in the New England Journal had similar results. But they used, rather than a rule-based system, they used a physiologic and mathematical model to modulate the instructions for insulin in children based upon their blood glucose and their trajectory. And they had as high as a 98% compliance. So I've covered human limitations, the fact that we need models and tools to achieve our desired actions because we are humanly limited. And there is a partial cure available with replicable methods like e-actions, for which I've given you a couple of examples. Here is a partial list of the people involved in this work that goes back decades. There won't be any quiz about this. And I was required to give you two citations if you want to pursue this. a group of 70 co-authors on 4 continents in 5 countries has recently reviewed this in some detail. So we have 15 minutes, and I might, with the help of IT, be able to get to reserved slides if you have comments, challenges, questions. Have at it. Any questions? Any concerns?
Dr. Morris. So you've proven that using the computer should be able to help us better. Why don't we? And what can we do to get people to do it?
Well, that is a central question. Thank you. Why don't we? I'll take a minute or two to answer that question. First, the first example I know of automatic control of mechanical ventilation, a life-saving maneuver, was published in 1957 from Harvard and MIT. The mechanical ventilator they were controlling was an iron lung, and the patient was a patient with paralytic poliomyelitis. Now that's about 70 years ago. So why have we not gotten there? We presented this in the 1990s to the president and 2 other senior executives of a major mechanical ventilation manufacturer in the United States. And their response was, and we said, you can have the program. We'll give it to you. Your mechanical ventilator is a computer. Just put the rules in there and let it run. And it's yours. And they said, well, the FDA might require us to only market with the rules, and that might reduce our sales. And as a result, we don't want to have any part of this. So I think the answer to that question is we have a cultural barrier. What's the cultural barrier? Well, it's people like me. I was trained and encouraged to become like Hippocrates. I never made it, by the way. What do I mean by that? I was trained to read everything I could, to learn everything I could, to know everything I could, and be the best expert when it came to making decisions for my patient, because that's how he got the best run for his money. And that model is a problem. The psychology literature is replete with information that clearly indicates that it's impossible to do that. It's impossible to keep up. Everyone in this room knows that. I mean, who here is keeping up with your own discipline, let alone general medicine? I suspect it's no one, because it's not possible. So we have a cultural barrier, and until that cultural barrier is addressed, and we understand better what our human limitations are and what our needs are in order to go from 50% compliance with evidence-based care to 95, or in some cases 100%, we are going to continue to have problems. Sir.
Thank you for your very insightful presentation. Fascinating. I have one observation and one question. And I will take orthopedic surgery as an example. Many conditions, our treatment cannot be based on level 1 evidence because that does not exist. And so we use our intuition and all these other subjective factors. My question is, how do you think that AI will impact this entire discipline that you've discussed.
Right. Thank you. That's a very important comment. What do we do? It's not just orthopedics. I mean, most of the questions in healthcare don't have evidence supporting them, right? I'm just talking about the few things for which we have good evidence. The management of heart failure. There's plenty of good evidence about managing heart failure. The management of asthma, chronic inflammatory bowel disease. There's enough evidence about that, but for most of the questions, we don't. So what do you do? I think what orthopods could do is extend what they've done anyway with prostheses, right? You're an orthopedist? Yeah. So probably in your hospital, a decade or two ago, you got together and said, hey, listen, we can't have 25 different appliances for the hip. Which ones are we going to use? How do we focus? Did you do something like that? Yeah. Okay. So did you have evidence? Well, not really. You had experience. You had players. The most experienced player, if your most respected clinician was someone who always used a particular appliance, that had a lot of weight. So when we don't have evidence, it's still possible, based on the assessment of thoughtful clinicians, to write rules for the management of a problem and then modify those rules based upon what we see happening. For example, you could think of the management of an orthopedic problem as a comparative effectiveness trial under usual care with two different sets of rules, one of which has what your preference was and one of which has what her preference was. And the two of you weren't sure which might be better, but you agreed that either one could be used. Now you got two arms. You randomly allocate patients to the two arms, and after a while, we learn which outcome's better, if there is one. Okay, next, to go to the question, AI. AI has a lot of potential, right? I mean, artificial intelligence has already impacted knowledge of protein folding and chemical interactions and led to the development of new drugs much more rapidly than could happen without. So is AI going to be useful? I think the evidence is clear. Is AI potentially dangerous? I think the evidence is clear. It is potentially dangerous. Could AI be a major threat to humankind? I think that's a possibility. Is AI likely to lead to, let's say, review of the major Ogden Hospital EHRs and tell us what the best care is? I think that's unlikely. Why? The EHRs are incomplete. The data are commonly not very reliable. I mean, I don't know what your experience is, but when my wife and I go to see people, we commonly are cared for by PAs or nurse practitioners, and when they go through the checklist and all the questions, the word which comes to my mind while they're getting our history is perfunctory. I mean, that's not what I was taught to do as a medical student. We were taught to follow leads. We were taught to look at patients. We were taught to interpret nonverbal communication, go down a different avenue. Doesn't happen. It's just a quick. So I'm very concerned that the signal-to-noise ratio for the outcomes we'd like to assess, how do patients with hips manage with a particular appliance do, the signal-to-noise ratio for those outcomes is very low because the EHR is so noisy. It's incomplete. It has a lot of questionable data. and it has a lot of good data. I mean, it's not as if it's useless. But remember, the EHRs were introduced by President Obama in a decision that some people, for legitimate reasons, question, without any evidence that it's going to have a good impact on patient outcome. I mean, we've spent, what, $80 billion in the country on EHRs? Where is the evidence that this helps us achieve our goal? Now, there was one. Some of you may know of Homer Warner at Intermountain and LDS Hospital. He built an EHR that was intended just to help clinicians take care of patients. It had no billing capability. The EHR that we used for this at LDS Hospital was very powerful, but the billing was done manually by somebody who looked at the EHR and entered it into a billing program. That's not exactly what happens with Epic or Cerner or the others. So I think AI will not solve this problem. I think that if we were able to pursue e-actions and get this, for example, get Ogden into a mode in which the EHR was now populated by very reliable data from a replicable method, that database might be operable with AI and might produce things that we otherwise couldn't anticipate. But right now I'm worried about signal to noise. Does that help answer your question? Okay. Any others? Just think for a moment. The next time you see a patient in the hospital getting kidney dialysis, why does that have to be done by people? I mean, we fly F-16s automatically. You don't think we can manage a kidney dialysis machine automatically? Or a mechanical ventilator? Or a balloon counterpulsation pump? Or use telemedicine to tell a heart failure patient who's gained 5 pounds in a day and is now coughing and can't get around the kitchen to do her housework. You don't think we have a program that feeds back and says, listen, take an extra dose of your water pill and take an extra dose of your potassium? And I mean, 30 years ago, we said we couldn't do that with PAs. And now it's routinely done with PAs and nurse practitioners. Now, one of the problems, you haven't asked about this, that physicians worry about is what's called de-skilling. If mechanical ventilators are automatically managed, and people like me won't be so facile managing mechanical ventilators, how many of you are facile using a slide rule? How many of the older members are facile using an abacus? We don't use them. Why? Those tasks are no longer necessary. It's a consequence of civilization's advance that a number of things that took an enormous effort now become replaced and free up time for other activities. So we might lose the skill to do mechanical ventilation. Remember, that skill only gets us to the right place about half the time. But we'd free up time, which I would like to have with my physician. I mean, one of the reasons I go to my primary care physician is he takes time to talk with us and to explore us, and he's careful with physical examination. That's frequently not the case when administrators give you 12 minutes for a follow-up visit, right? It's 12 o'clock. I have something at 6 p.m., so I only have 6 more hours. Are there any other questions? Comments? Okay, thank you very much.
I should try this out. I think it looks good on me, Dr. Morris. Okay. Thank you so much for that talk. Sorry. I wanted to remind you as well that we have our gamification app through the app for the Invent Mobi. So if you go around and visit our vendors, the booths, you can enter in, you can answer those questions, enter in. The grand prize is a fancy leather planner, and there are 7 runners up, and you get a pair of socks. Really cool pair of socks, apparently. And now we'll break for lunch, and I personally hope that we're going to get some ghost broccoli. Sounds really good, yeah. Maybe, but even regular broccoli would be okay. Anyway, have a great lunch. This was a great morning. Thank you, guys.